Hi, everybody, and welcome to APASL 5th webinar on COVID-19. I am Professor Yokosuka from Chiba University, Japan. I was the president of APASL 2016 in Tokyo. I'm going to chair this seminar with Professor Gani from Indonesia, although not connected at this moment. Professor Gani is the president of APASL 2020 in Bali, as you know. Today's seminar is on hepatocellular carcinoma. I think SCC is very important for all of us, APASL people, because hepatocellular carcinoma is very common in this area, and majority of SCC cases are living in Asian Pacific region, where hepatitis B and C are very common. Today's speaker is Professor Shiina from Juntendo University in Tokyo. I will introduce him. He is a graduate of University of Tokyo and got his PhD with a study of randomized controlled trial with ethanol injection therapy, PATE, and RFA in small hepatocellular carcinoma. He moved to Juntendo University in 2012. He is an expert on local regional therapy of SCC and performed more than 11,000 patients, performed RFA on 11,000 patients with liver tumor. He was president of APASL Single Topic Conference 2018 in Yokohama and on ACC. Today, he will talk on diagnosis and treatment of SCC, how to manage SCC in COVID-19 pandemic era. Professor Shiina, please start your lecture.
Yes. Hello, everyone. I'm Dr. Shiina of Japan. Today, I will talk about consensus recommendations on the management of hepatocellular carcinoma. I'm sorry. Where's my... Oh. COVID-19 is an infectious disease caused by the novel coronavirus, and it has been giving the devastating impact on the recurrent medical care system. As of 7th of May 2020, COVID-19 epidemic has resulted in over 3.7 million confirmed cases across 215 countries, areas, territories, and over 215,000 deaths. A new model study showed that intermittent period of social distancing strategies will be needed into 2022 to ensure that the medical system has enough critical care capacity for future COVID-19 patients. There are quite many guidelines and recommendations on COVID-19. However, there are only few guidelines and recommendations on the management of hepatocellular carcinoma during COVID-19 pandemic. Liver cancer is the fourth most common cause of cancer-related deaths in the world, which caused 782,000 deaths in 2018. More than 90% of liver cancer is hepatocellular carcinoma. The majority of cases of hepatocellular carcinoma are found in the Asian Pacific region. Regarding COVID-19 and cancer, patients with cancer may be susceptible to infection during the viral epidemic than individuals without cancer. It is due to their systemic immunocompromised state caused by the malignancy and anti-cancer treatment, which might also be at increased risk of severe COVID-19. Patients with cancer have a significantly higher risk of severe events, such as being admitted to the intensive care unit requiring invasive ventilation and death compared with the patient without cancer. Regarding the COVID-19 and chronic liver disease, most patients with hepatocellular carcinoma have underlying chronic liver disease resulting from chronic HBV or HCV virus infections, alcoholic liver disease, and non-alcoholic fatty liver disease. No evidence suggests that patients with chronic liver disease are at increased risk of the novel coronavirus infection. Generally, a diagnosis and treatment of hepatocellular carcinoma, which is a highly malignant tumor, should not be delayed because of the pandemic of COVID-19. However, for the patient with confirmed or suspected to have the novel coronavirus, diagnosis and treatment of hepatocellular carcinoma should be postponed until the virus is eradicated or they are confirmed as not being infected with it. The indication and principle of management of hepatocellular carcinoma should be the same as in non-pandemic circumstances. Regarding hospital preparedness for COVID-19, not only all patients, but also all staff are at risk of being asymptomatically infected with the novel coronavirus in the pandemic areas. So, if circumstances allow, hospital preparedness is recommended as follows. Minimal exposure to medical staff by using telemedicine wherever possible. Use of the appointment registration system. Set up pre-reception inspection, including checking body temperature and questionnaire with symptoms such as fever and cough, respiratory syndrome symptoms, recent history of close contact with confirmed or suspected person to have the novel coronavirus. Regarding the surveillance for hepatocellular carcinoma, it is recommended to limit the usage of ultrasound. Since ultrasound practitioners are in close contact with patients, as a protection for both ultrasound practitioners and patients, surgical face masks are necessary for ultrasound practitioners. Patients are also suggested to wear face masks. Every patient should be considered as possibly infected to the novel coronavirus. Therefore, after each examination, thorough cleaning of a gel bottle and all touched surfaces should be performed using disinfectant. Regarding the diagnosis for hepatocellular carcinoma, in general, dynamic CT, dynamic MRI, or EOB MRI is recommended as a first-line diagnostic tool for hepatocellular carcinoma when a screening ultrasound shows a possible HCC nodule. Contrast-enhanced ultrasound, which is very sensitive to detect hypervascularity in the nodule, and ultrasound practitioner. As every patient possibly infected with the novel coronavirus, those who have an abdominal CT in their investigations may also have a chest CT scan at the same time. However, we don't recommend CT screening for COVID-19 as they did American College of Radiology, Royal College of Surgeons of England, Royal College of Radiologists do not recommend CT screening for COVID-19. So chest CT should only be deployed in very specific circumstances. CT screening for COVID-19 has a low pickup rate in asymptomatic patients infected with novel coronavirus and a 20% false negative rate even in symptomatic patients. Regarding treatment for hepatocellular carcinoma, American College of Surgeons recommended elective surgery acuity scale to further assist in the surgical decision-making process to triage non-emergent operations. Hepatocellular carcinoma and most cancers are considered as progressive diseases. Thus, it is recommended not to delay its curative treatment, such as surgery and ablation. This is the elective surgery acuity scale. Divided non-emergent operations into 6 subcategories, and most cancers are here, 3L3A. So the treatment in 3L3A should not be postponed. So liver resection without curative intent should not be delayed. However, in cases of high risk of decompensation or comorbidities that increase the risk of severe COVID-19, surgical intervention should be postponed. One alternative therapy, such as ablation, should be adopted. Liver transplantation for patients with poor short-term prognosis is in high priority and should not be delayed. However, elective living donor transplantation should be suspended to minimize the risk of the donor and the recipient. In patients with complete response to bleeding therapy on transplant list, transplantation should be delayed. Regarding ablations, so image-guided percutaneous ablation such as radiofrequency ablation, microwave ablation, and others are minimally invasive therapies for hepatocellular carcinoma. Ablation with curative intent should not be delayed. This is our ablation suite. The patient is now in the upright position, and I treated the tumor in the left lateral subsegment. This is the results of the SURF trial. randomized control trial between the surgery and radiofrequency ablation. And in such trials, recurrence-free survival was not different between surgery and radiofrequency ablation. Hazard ratio was 0.96. The recurrence-free survival was not different between the two therapies at all. So in cases of 3 or fewer tumors, each 3 centimeters or smaller, and whose liver function is Child-Pugh class A or B, ablation is an acceptable alternative to surgical resection. Ablation itself is not an aerodol-generating procedure. So ablation is performed with local anesthesia in many institutions, and ablation with local anesthesia is not an aerosol-generating procedure. So we only need a standard personal protective equipment. I wear head covers, eye guard here, and surgical mask, isolation gown, and gloves. Patients also should wear a face mask, and the oxygen mask should be on the top of it. But in some institutions, ablation is performed with general anesthesia, like this. So general anesthesia is considered an aerosol-generating procedure because of intratracheal intubation. So when general anesthesia is performed, ablation rooms have to be considered as high-risk areas of infection. So they need to have a higher level of PPE. Vascular interventions such as transcatheter arterial embolization and hepatic arterial infusion chemotherapies are not aerosol-generating procedures. So vascular interventions are used not as a curative, but in many cases, vascular interventions are used not as curative treatment, but as cytoreductive treatment. So vascular interventions, most vascular interventions should be postponed in cases of high risk of decompensation or comorbidities that increase the risk of severe COVID-19 because of the reduced inpatient beds for post-procedure care. Radiation therapy is used for asymptomatic bony metastasis and other conditions. Palliative care patients receiving the therapy to control symptoms or at low risk of progression, it's better to delay the schedule of radiation. However, radiation therapy for patients with rapidly progressing hepatocellular carcinoma may outweigh the risk of novel coronavirus infection. Function or life-threatening situations such as spinal cord compression and inferior vena cava syndrome have to be treated without delay. Regarding systemic therapies, in patients with advanced hepatocellular carcinoma who require systemic therapy, oral tyrosine kinase inhibitors would be better than infusion regimens in the pandemic era to protect both patients and medical staff. If available, video calls should be used to manage common adverse events. Intravenous chemotherapy should be administered in a dedicated session of outpatient service. The impact of immunotherapy on the course of COVID-19 is not known because there is no sufficient data. Regarding follow-up for hepatocellular carcinoma, it is generally recommended to follow up the patient by telemedicine or online consultation, and to avoid hospital visit in the circumstances of COVID-19 pandemic. However, due to its high frequency of the recurrence in HCC, imaging examinations such as contrast-enhanced CT or contrast-enhanced MRI to detect recurrence at an early stage should not be postponed. We need to detect a recurrence at an early stage, even in the era of COVID-19. So we should do the those follow-up as usual. So I'd like to summarize my talk. These recommendations have been developed to preserve and sustain adequate clinical practice in the management of hepatocellular carcinoma in the era of COVID-19. They are collection of measures implemented by frontline medical professionals. These recommendations are likely to evolve over time as future data becomes available. Thank you for your attention.
Thank you, Professor Shiina, for your nice lecture. And there's only one question, but not so much related to the COVID-19 infection. First one is RFA versus microwave ablation in HCC, which is better?
I think so now at present we need both, because microwave ablation can produce a large ablation zone in a shorter period of time, ablation time. However, so at present, we mainly use the imprint, and we can get a larger volume of ablation in a shorter ablation time. But the antenna of microwave ablation is somewhat more difficult to insert into the tumor. So if the tumor is located in a very delicate area at a site of risky location, I would like to use radiofrequency ablation. So we use both microwave ablation and radiofrequency ablation at present. So if the tumor is located not so difficult site, in that case, I prefer to use microwave ablation, because microwave ablation can get the larger ablation volume in a shorter time. But so if the tumor is located in a very delicate place, like any other Grisonian thighs or near the heart, in that case, I'd like to use radiofrequency ablation.
Okay, thank you. And in your talk, you are rather very aggressive for the treatment of hepatocellular carcinoma in general, but then Uh, well, it depends upon the situation. And about the diagnosis,
Yeah.
uh, uh, how to diagnose the faster progression of SCC by maybe uh, tumor marker like FP, alpha fetoprotein, or PBCA2. How to diagnose the faster progression of SCC?
So maybe so we need to check the change of the value of the tumor markers such as AFP and PBCA2. So the tumor markers elevate in a shorter duration. In that case, we think that this HCC, this tumor is very aggressive. We need to very progressive, so we need to treat without delay. But maybe if the tumor marker is not so change so fast, in that case, maybe we can wait. But of course, the hepatocellular carcinoma is not so disease that we can wait in general. So if the circumstances allows, we should do the ablation. Do the
Um,
treatment. I'm sorry.
I think ultrasonography is rather risky for doctors and maybe and also patients.
Yes.
So not so recommended to do frequently. How do you select cases of ultrasonography?
So yeah, as you said, the American Society of Ultrasound in Medicine and World Federation of Medical Ultrasound do not recommend ultrasound for screening in the era of COVID-19 because the ultrasound examination, yeah, there is a close contact between the practitioners and their patients. So, and we do not, at present, we do not use ultrasound at all for the screening. We use ultrasound in cases in which ultrasound is definitely needed, like the to detect the so if there are some if we in cases in which the uh, contrast enhanced CC or MRI suggest the hepatocellular carcinoma, but it's not definite. In that case, so I would like to use the contrast enhanced ultrasound like that.
Yeah, about avoiding the infection of COVID-19, I wonder whether is there any well check of the COVID-19 infection in medical staff and patients. Do you have to perform the PCR in every patient
No,
or every medical staffs?
in Japan, so, so we don't check, we don't do the PCR so frequently. Maybe even PCR is not, the sensitivity is not so uh, very high. Maybe around 70% or so at highest. So, and so uh, in Japan, we do PCR only in cases in which uh, the novel coronavirus infection is strongly suspected. I mean, in patients with symptoms which suggest the COVID-19. In that case, we do PCR, but no, we don't use PCR for the screening of the novel coronavirus infection. But so we think we should think all people, not only patients but also our medical staff, have a chance of being infected with the novel coronavirus.
So the possibly risky patients should be checked infection.
Yeah. Yes.
Okay. Thank you. And the next question is: should chemoembolization always be postponed during COVID pandemic? If the tumor site is not big and it has low risk of liver decompensation after treatment, isn't it be better to continue chemoembolization to this case?
Maybe so.
If the tumor is not so progressive and rather small, you don't need to do chemoembolization. It can be postponed.
Yeah.
Okay.
Yes. We think we can postpone or yeah. If we can do if there is a chance of curative treatment, maybe we would choose the other treatment like ablation or radiation therapy or surgery. Yeah, but maybe the chemoembolization is performed only for the site reduction palliative purpose. In that case, we think we should postpone chemoembolization in most cases.
Thank you. Well, the next question is: does COVID worsen HCC? It is reported that COVID could induce impaired liver function. If this is the case, would the injury from bile duct or hepatocyte? Thanks. Next question is like this. I don't think there's no data whether the COVID worsened HCC or not. Okay.
No, I don't think we have enough data about it. Next question is: what kind of protective equipment do you wear in the outpatient clinic at this time of COVID era? Outpatient clinic, just only telemedicine, or if you contact face to face, you have any protective equipment? Just mask? I have a surgical mask and the eye guard, face shield, but face shield is from upside down, but I use the eye guard on the mask. I attach the eye guard on the mask.
Mask and maybe face shield.
Yes. Yeah. Yes.
Yeah. About chemotherapy and immunotherapy, is there any additional side effect of sorafenib in patients of HCC with COVID-19? Maybe we don't have any data, but how do you think about it? Is there any extra additional side effects?
We don't think we have any data about it, but if the patient has a definite, if the patient is confirmed to be infected with the novel coronavirus, I think we should wait. We should postpone the treatment for a while. We should, we should not do the sorafenib for a while until the virus is eradicated.
Well, about immunotherapy, there's a disturbance of immunity by the treatment. Uh, I wonder whether you should consider the postpone the immunotherapy and whether which do you prefer, chemo, uh, uh, immunotherapy or just kinase inhibitor?
Maybe I think the tyrosine kinase inhibitor would be safer. We have more data probably, so we have more history of using the tyrosine kinase inhibitor. So to be on the safe side, I would like to use tyrosine kinase inhibitor.
Yeah. Sorafenib uh, is preferred first and, than immunotherapy. Well, about the next question is, in case of portal vein thrombosis,
Yeah.
what should be done? TEER versus SPRT and then TACE. What are you going to do in case of portal vein thrombosis?
So in Japan, TI is not available probably in our daily practice. So so SBR, the tumor is only localized in one area. We use the radiotherapies, including the heavy ion beam therapy or proton beam therapy like that. And the tumor is in many areas, in many sites. In that case, and so it's a common practice in Japan to hepatic arterial infusion chemotherapy.
Well, about follow-up, should we continue SCC surveillance every 6 months or can it be done every 12 months instead? About the surveillance. And then maybe follow-up, how do you think? Every 3 months or 6 months or 1 year?
Okay, so about the surveillance. So I think it depends on the risk of developing hepatocellular carcinoma. So there are high risk groups such as chronic hepatitis B virus infected HBV related chronic hepatitis or HCV related chronic hepatitis or liver cirrhosis of any etiology. But there are some very high, super high risk groups such as liver cirrhosis due to hepatitis B virus or hepatitis C virus in that case. So, of course, it depends on the capacity of the institution, how many patients we can do the surveillance. So, if our capacity is limited, we should do the surveillance on the super high risk groups, such as patients with liver cirrhosis due to hepatitis B or hepatitis C virus infection, because they have a higher chance of higher risk of developing HCC than those with chronic hepatitis or with liver cirrhosis of other etiologies. So our capacity is limited. Surveillance should be the patient with super high risk of developing HCC should have the priority and the follow-up after the treatment. If we do the curative treatment, maybe I said we should do the follow-up. under normal circumstances, because if possible, yeah. So
Yeah. Okay, depend upon the capacity and risk of the uh, uh, development of SCC,
yes.
maybe. Well, we have several questions, but at this moment we can connect with Professor Gani. So if Professor Gani have any comments, please, Professor Gani.
Oh, hi to all of you. And Professor Shiina,
Yeah.
I'm very sorry. I'm still in the hospital. Yeah, doing some kind of a complicated procedures. Yeah, I think in this era of COVID-19, I think we have to consider the surveillance, which is very important in the prevention or treatment of hepatocellular carcinoma. So yeah, maybe we can have a kind of a consensus regarding the surveillance of the hepatocellular carcinoma in patients with in patients with chronic advanced liver disease, especially like us in Indonesia and maybe also in other part of the world. The patients with telemedicine, yeah, telemedicine. So patients can consult us without seeing the doctors. In this case, I think it's more. It becomes more important to point out or to stress the importance of surveillance in patients with advanced liver disease. I think that's my comment in management of liver cancer.
Yeah, thank you.
Okay, thank you, Professor Gani, and thank you, Professor Shiina, for your nice lecture. And at the end of this webinar, I'd like to ask Professor Lau, because he is going to finish the APASL guidance for COVID-19. Professor Lau, George?
Yes. It's a very nice presentation, Professor Shiina. Thanks for the wonderful talk. And I think that HCC in the era of COVID-19 is very important in terms of our elective services, also emergency service. And maybe it's time for us to segregate and to allow some delay in certain low-risk patients in terms of HCC surveillance. I just type in. In fact, we should try to prioritize the service because the safety of the medical professions and also the patients is of utmost importance. And we need a concerted effort to control the COVID-19. The mentioning about TKIs and also the immunotherapies is very important because we do not have data. Maybe my personal experience is maybe we should allow the immunotherapies in those less severe cases. And while in those with advanced or with a risk of disease progressions, we should withhold. We just have a paper published of the risk score on the predicting disease severity. And maybe this is useful in terms of those who are old age, obese, with comorbidity factor. Maybe we should not consider immunotherapy. But for those with low risk of progression, so we might still need to give PD-1 blockers as a form of therapy for HCC. That would be my comment. But we have a lot to learn, because new drugs is coming in, drug and drug interactions with remdesivir and also the Avigan from Japan. There are lots of data which needs to be filled in, and especially as a hepatologist, we might be called upon to be consulted for liver enzyme derangements. So I hope that the guidance would be helpful, and we will have an update with the input from all of you from time to time. Thank you very much.
Thank you, Professor Lau. Well, time is up, so we have to close this session. I'd like to thank you for all the audiences for the fruitful discussion. Thank you very much.
Thank you very much.
Thank you all.
Thank you.
Thank you very much.